بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على رسوله الكريم سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, we are continuing the gastrointestinal imaging series, and we have finished the sector of the esophageal imaging. Now we are continuing the series by discussing imaging of the stomach. And you all know that in the previous days we used to examine the stomach by barium, and we used to give some barium fluid to the patient, and we put the patient in different positions on the radiographic table, aiming at examining the stomach, partly filled with barium and partly filled with air along the different parts of the stomach. And we used to give some of the gas producing powders to the patient in order to produce some gastric distension with air together with the previously introduced barium fluid. Then we radiograph the stomach in different positions while the patient is lying on the supine position or elevating his left side or right side, or putting the patient into the lateral position, aiming at radiographing the stomach or every part of the stomach, once filled with barium and another time filled with air. This position is useful for detection of gastric filling defects and masses, and this view is suitable for detection of mucosal lesions like ulcerations and mucosal hypertrophy. Also, one of the techniques which were used in previously was the test for gastroesophageal reflux. We put the patient on the supine position or on his left lateral position. Then we ask the patient to swallow some amount of water, and we look at the gastroesophageal junction. If the patient had some gastroesophageal reflux, then we'll see the barium is coming from the gastric fundus into the lower part of the esophagus, as you can see in this patient. And we have discussed in details the issue of GERD, or gastroesophageal reflux disease, and how to diagnose this disease and the complications expected from the long-standing gastroesophageal reflux. Now, in the sector of the stomach, we would like to discuss the issue of gastric diverticulitis, the types of gastritis and gastric ulcerations. The Zollinger-Ellison syndrome, hiatus hernia, have been discussed with the esophageal sector. Gastric volvulus, gastric bezoars or foreign bodies, and the gastric neoplasms. Will also have a look on the duodenum, considering ulcerations and diverticuli. Then gastric diverticuli are rare, and this is the incidence 0.04%, and it is usually asymptomatic, and very commonly gastric diverticuli occur in the fundus. And as you all know, the common complications that are expected from a diverticulum anywhere in the gastrointestinal tract are these two major complications, which are bleeding and perforation. Then this is a barium study showing a typical gastric diverticulum in a typical location, which is in the gastric fundus. Duodenal diverticuli are considered the second most common GI diverticuli after those of the colon, and this is the incidence. About 6% of upper GI examinations may show duodenal diverticulum, and this diverticulum is a false diverticulum made only of mucosa, and is very commonly occurring in the second part of the duodenum, very close to the region of the ampulla of water. And this is a small duodenal diverticulum which is located in the second part of the duodenum, and this is also a large duodenal diverticulum which is seen in the third part of the duodenum. And in cases of large diverticuli, you may see air fluid level, as you can identify in this particular case. Then we came to the issue of gastritis, which means that there is some kind of inflammation or irritation associated with or without erosion of the mucosa. And there are two main types of gastritis, the acute type and the chronic type. And here are the causes: excessive alcohol intake, prolonged use of non-steroidal anti-inflammatory drugs, surgery, major traumatic injuries, burns, and some kinds of severe infection. While in chronic cases, the stress and H. pylori, also the chronic bile reflux into the stomach or autoimmune disorders may be responsible. And the symptoms of gastritis may include some abdominal pain or upset, indigestion, abdominal bloating, nausea, vomiting, and the pernicious anemia due to continuous loss of blood. Also, you should remember that gastritis may be totally asymptomatic. Then we have I have mentioned that we have acute and chronic gastritis, but this erosive gastritis means that there are some erosions in the gastric mucosa, and this can occur in many disease conditions, and you can see some of them, like this Crohn's disease, which will be discussed in details in the sector of the small bowel, the herpes simplex, cytomegalovirus, fungal infection, candida, the syphilis, alcohol and aspirin indigestion, steroid and non-steroidal anti-inflammatory drugs, and also the stress, as in cases of burns and trauma. Then if you look carefully, and you can see some flecks of barium within the mucosa, and these flecks of barium are surrounded by a radiolucent halo, what we call the halo sign, and this is the classic appearance of gastric erosions or erosive gastritis. As you can see here, this is the site of the ulcer, and the radiolucent rim represents the surrounding halo of mucosal edema. Then you should know that chronic gastritis is not a radiological diagnosis, and it is only a histologic diagnosis. And in cases of chronic gastritis, you can see erosions, you can see hypertrophy of the mucosa, and you can see atrophy of the mucosa. All these findings can be identified on the barium studies, and also can be seen by endoscopic examination of the stomach. Here you can see a case of chronic gastritis where there is considerable thickening of the mucosal folds, especially in the fundus and in the gastric body. And in this case of histologically diagnosed chronic gastritis, you can see mucosal atrophy in some parts of the stomach and mucosal hypertrophy in the body and the fundus. And in this case, you can see also the mixed type of mucosal atrophic changes and hypertrophic mucosa as well. And this is a type of H. pylori gastritis, and whenever you see this hypertrophy of the mucosal folds, and you may go into a long list of differential diagnoses, which include gastritis, of course, and maybe sometimes some types of gastric neoplasms, especially the lymphoma. And for this reason, a mucosal biopsy is usually indicated in order to confirm or to disprove the possibility of a malignant lesion. then this appearance should not or may be mistaken for hypertrophic gastritis, menetrier disease, or lymphoma. And as I have mentioned, you need the help of endoscopic biopsy to confirm the diagnosis. And this is an easy diagnosis where you can see a severe atrophy of the gastric mucosa and the relative narrowing of the gastric lumen, so that the lesser curve and the greater curve are almost parallel to each other. Then one type of gastritis is what we call the granulomatous gastritis, and many of the diseases can cause this type of gastritis, like TB, sarcoid, histoplasmosis, Crohn's disease, and eosinophilic gastritis. And you should remember that we cannot by radiology and even by histopathology discriminate between these types of granulomatous gastritis. Then we came to the gastric ulcers, and we have two types, the benign type and the malignant type. Gastric ulcers are common and are seen in about 30% 30% of peptic ulcers are seen in the stomach, and about 5% of gastric ulcers are on the malignant side. Then if the ulcer is small than 5 millimeter, you cannot usually detect by barium studies. And if the ulcer is large than 3 centimeter, then the risk of complications is high. And the complications, as you know, include bleeding and perforation. Then how to discriminate between benign and malignant gastric ulcers? I think the only radiological landmark is to look the mucosal folds and the ulcer edge. If you can see that the mucosal folds could be traced along the course of the mucosa until the edge of the ulcer, then you may safely call this is a benign gastric ulcer. And here is an example of a benign gastric ulcer, where you can see that the mucosal folds are reaching the edge of the ulcer. And this is also an example of a benign gastric ulcer, and you can see the mucosal folds even going into the base of the ulcer. And this is what we call the bullseye ulcer, which is usually seen in cases of erosive gastritis. And you see the fleck of barium, which is surrounded by a halo of edema. And this is also an example of benign gastric ulcer by barium meal and by endoscopic examination. And it's easy for you to realize that the mucosal folds are reaching the edge of the ulcer, and this is diagnostic of a benign lesion in most of the cases. But if you look to the mucosal folds, and you can see that the fold is stopped away from the edge of the ulcer, like this fold and this one, then you know that this is a malignant ulcer infiltrating the adjacent muscularis, the adjacent muscle layer of the stomach, as well as the mucosa. And so the mucosal folds cannot reach the edge of the ulcer because there is a malignant invasion of the peri-ulcer area. Then this is one way to discriminate by radiology, but you can also use endoscopy and biopsy to confirm the diagnosis. And here is an endoscopic or histopathologic or pathologic specimen of a gastric ulcer which is malignant, and you can see that the mucosal folds are not reaching the ulcer edge, and the ulcer edge is indurated and everted, as we have been taught about the criteria of malignancy in ulcers. And here is an example of malignant gastric ulcer, and you see the mucosa is not reaching the edge of the ulcer, and this is also one of the helpful diagnostic criteria. Most of the duodenal ulcers are on the benign side, and about 70 to 90% are associated with H. pylori infection, and the ratio between or the incidence of the duodenal ulcers against gastric peptic ulcers, as you can see that they are more common in the duodenum compared to the stomach. And the duodenal ulcers, as I have said, are generally benign, and you know that the benign ulcer is a an area of localized persistent barium collection, and the mucosal folds are seen reaching the edge of the ulcer. And here is the typical appearance of acute duodenal ulcer in the duodenal bulb. You see the mucosa is reaching the edge of the ulcer, and the persistent area of barium collection in this duodenal bulb. And this is also a typical appearance of acute duodenal ulcer, a collection of barium in the duodenal bulb, and you see the mucosa reaching the edge of the ulcer. And after healing of an acute duodenal ulcer, there is some kind of fibrosis and contraction and the deformity of the duodenal cap. And in this situation, you can see the typical appearance, which is known as the trifoil deformity of the duodenal cap. And here you can see the trifoil deformity, indicative of the presence of chronic ulceration, cicatrization, and fibrosis. And this is also another example of the trifoil deformity of the duodenal cap by barium meal, indicative of chronic duodenal ulceration. Then this syndrome is characterized by a triad, which includes gastric acid hypersecretion or hyperacidity, severe peptic ulceration, which are usually multiple and are usually located in atypical locations. Then the third part of the triad is the presence of a non-beta cell islet tumor of the pancreas, which is the gastrinoma. Then symptoms of this syndrome include abdominal pain, diarrhea, and severe peptic ulcerations of the stomach and maybe the small bowel. And these ulcers are usually not responding well to the medical treatment. Then gastrinoma is a non-beta cell islet tumor of the pancreas, and it may be single or multiple. And single gastrinomas are usually malignant in about 50 to 60% of cases, and 25% of patients have gastrinomas that are multiple, and this is considered a part of the multiple endocrine neoplasia syndrome type 1. And in this MEN syndrome, patient may have tumors also in the pituitary gland as well as in the parathyroids. And this is an example of a gastrinoma in the region of the pancreatic head, and you can see a big metastatic deposit in the right lobe of the liver. In this example, you see 3 gastrinomas in the pancreatic head, and you see this is 1, 2, and 3 lesions that are enhancing, and this arterial phase CT examination of the abdomen, which is considered a part of this Zollinger-Ellison syndrome. And this syndrome, as I have mentioned, you got gastric hyperacidity and hypersecretions. Then the mucosal folds will be hypertrophied and prominent, and usually there is poor coating of the mucosa by barium due to the presence of hypersecretions. As you can see in this case, there is a relative dilution of the barium, poor coating of the gastric mucosa, hypertrophy of the gastric mucosa, as well as the duodenal mucosal folds. Then this Zollinger-Ellison syndrome is characterized by multiple gastric and duodenal ulcers, and distal duodenal ulcers are highly suggestive of the disease. you know that the most common site of the peptic ulcer in the duodenum is in the first inch of the first part, or what we call the duodenal bulb. But if you see duodenal ulcers in the distal parts of the duodenum, in the second and the third part of the duodenum, then you may think of this particular syndrome. Then gastric and the duodenal mucosal fold thickening and the hyperexcretion, as I have said, can lead to barium dilution and poor coating of the mucosa. And this is an example of Zollinger-Ellison syndrome with hypertrophied nodular appearance of the gastric mucosa, and also you can see that the duodenal curve is markedly widened and compressed, assuming that there should be a mass in the pancreatic head which represents this gastrinoma, and the combination of this and this is an indicative of this syndrome. Then we have discussed the four types of hiatus hernia in the sector of the esophagus, and this is just an example of hiatus hernia which is incarcerated as indicated by the presence of air fluid level in the retrocardiac area. And if you see in the chest x-ray this particular finding, and you think that this hiatus hernia is no more sliding, but it is now carcerated, so it cannot go back into the abdomen, then you got the presence of air fluid level, which is clearly seen in the lateral view. Then the gastric volvulus, it means that the stomach has been rotated along a certain axis, and we have two types, the organoaxial and the mesentericoaxial volvulus of the stomach. In the cases of organoaxial volvulus, the greater curvature is above, and in cases of mesentericoaxial volvulus, the greater curvature of the stomach will be on the right side. Then if you look to the barium study, and you can see that the greater curvature is above, this is the fundus of the stomach, and this is the body, and this is the pylorus, and this is the duodenum. And if you look carefully, this is the esophagus coming posterior to this to reach the gastroesophageal junction here. Then gastric volvulus is a common situation, particularly in cases of diaphragmatic hernias and paralysis or eventration of the diaphragm. And the organoaxial type of gastric volvulus is more common than the mesentericoaxial type of the volvulus. And here you can see that this is the fundus, and this is the greater curvature of the stomach, which is facing upward, and this is the duodenum and the rest of the duodenal loop. Then this gastric volvulus is almost always part of a large diaphragmatic hernia. If you remember, we have the four types of hiatus hernia, and the third type will include part of the stomach as well as the gastroesophageal junction above the diaphragm, and the fourth type you got part of the stomach as well as other abdominal organs herniating into the lower part of the chest. Then gastric volvulus is a common complication of paraesophageal hernia, which is the second type of hiatus hernia. And if there is twisting of the stomach more than 180 degrees, there will be obstruction to the gastric outlet. Then this is the symptoms: abdominal pain, vomiting, and inability to pass the nasogastric tube in some cases, and this is organoaxial gastric volvulus as well. This is also organoaxial gastric volvulus, where you can see that the greater curvature of the stomach is facing up. Then you came to the issue of gastric foreign bodies, which are known as gastric bezoars. And these bezoars are the collection of indigestible material in the stomach usually, but sometimes can be seen in the small bowel. And 90% of these bezoars are seen in females, and it has an intimate relation to some psychiatric disturbances in most of the cases. Then the type of the bezoar, according to the type, the name is. And here, if the bezoar is made of hair, then it's called trichobezoar. Vegetables and the fruits, and this is phytobezoar. The medications is known as pharmacobezoar, which is made of tablets or semi-liquid masses of drugs. The most common type of gastric bezoar is that made of hair, and you know that hair is indigestible, and some of the mentally defective patients may swallow a large amount of hair, which may accumulate and block the stomach. And you see here there is a big mass of bezoar filling most of the stomach, and this mass may accumulate proximal to gastric outlet obstruction, or secondary to poor gastric motility, or the sequelae of inadequate chewing of food, or the massive overindulgence of food with high fiber content. And this is a 14 years old female who is mentally disturbed, eating hair on hair. And you can see that the stomach is distended with the large mass of foreign material, of course, made of hair inside the stomach. And you know that in order to get rid of this bezoar, you should have surgery, and the stomach should be evacuated from this massive accumulation of hair, as you can see. Then if the bezoar has a component in the stomach and has extended into the small bowel, and this is known as this syndrome, I assume that is Rabin-Zell syndrome. And this is the surgical evacuation of one of the gastric bezoars. You know, the backed hair material, which is taking the shape, almost the shape of the whole cavity of the stomach. Then the bezoar is a mobile intragastric foreign body, and it can be differentiated easily from the tumors by the presence of barium within the intersects of the this foreign material. And some of the bezoars, you cannot have a certain name for this type of bezoar, and this is the material that have been swallowed, and you got two of these material inside the stomach. This is the barium, and this is the endoscopic appearance of gastric bezoar, made of some of the plastic threads which are indigestible, that has been accumulated inside the stomach, blocking the whole cavity of the stomach. Then we came to the polyps, and you know that polyps may be benign and may be malignant. And one of the best criteria to differentiate benign from malignant polyps is the presence of a pedicle. If the polyp is pedunculated, we assume that is benign, but if it is sessile, it may be benign or may be malignant. Then these are the types of polyps: post-inflammatory, hyperplastic, adenomatous, hamartomatous, and the eosinophilic granulome. One of the common syndromes that will be discussed in details in the sector of the small bowel is the Budd-Juger syndrome. And this Budd-Juger syndrome is characterized by the presence of many polyps along the whole gastrointestinal tract, into the stomach, into the small bowel, as well as in the colon. These polyps are usually benign, and you see multiple small polyps within the stomach on barium study, and you can also see the appearance of one of these polyps by endoscopy. One of the typical criteria of this Busch-Jaeger syndrome is the presence of this characteristic pigmentation of melanin deposit around the mouth, as you can see. And this is also a case of Busch-Jaeger syndrome, where you can identify multiple intragastric bolovoid filling defects occupying most of the gastric body and antrum. Then we came to gastric carcinoma, which is considered rare before the age of 40 years according to the literature, and it has an intimate relation to the H. pylori infection, and it has been stated that about 8 to 10% of these tumors are inherited as has a familial inherited component. Then the criteria of gastric malignancies include filling gastric masses causing filling defect, destruction of the mucosa, reduction of the gastric lumen, irregularity of the gastric wall. As you can see in this case, there is reduction of the gastric lumen and marked irregularity along the curve, the greater curvature of the stomach. And in this case, you see an infiltrating type of gastric adenocarcinoma involving the distal part of the body and the pyloric canal. And proximal to this carcinoma, there are a lot of retained food material within the fundus and the proximal body. And in the mucosal relief film, you can see the irregularity and the destruction of the mucosal folds in the affected area. Adenocarcinoma is the most common type of gastric cancer, representing about 95% of malignancies of the stomach. And other cancers will include lymphoma. Other malignant types will include lymphoma, sarcoma, and carcinoma tumor, in addition to gastric metastasis. Then the appearance of early gastric cancer may be in the form of a small ulcer with the mucosal folds are not reaching the edge of the ulcer, as I have mentioned, or you see a small bulboid lesion, which is most commonly sessile and associated with localized mucosal thickening. But this is an appearance of an advanced gastric cancer with a large mass coated with barium in the gastric fundus, as you can see here. And this is also an example of a large gastric carcinoma infiltrating the greater curvature of the stomach with irregularity of the tumor edge. And the CT is one of the helpful diagnostic modalities for evaluation of patients having gastric cancer. It can identify the primary tumor, it can assess the extent of the tumor outside the stomach and the invasion of the adjacent organs. It can also assess the metastatic lymph nodes and can see distant metastasis in the body. In this particular patient, you can see this is the stomach, and you can see a mass which is infiltrating the greater curvature of the stomach near the gastric fundus, and this mass has been proved to be gastric carcinoma. Then this is the remaining part of the exam, and you can see the invasion of the wall of the stomach, and you see the irregularity of the tumor surface as well as the irregularity of the gastric wall. And this is another example of gastric adenocarcinoma infiltrating in the region of the pyloric canal. And this is the gastric fundus, as you know, and this is the mass of the tumor, and it may has been extended into the proximal part of the duodenum, as you can see in this images. And this is the gastric fundus adenocarcinoma infiltrating the fundus of the stomach, and the fundus has been reduced to this narrow tract, and this is the mural part of the tumor, and here also the mural part of the tumor, and you know that this area is near to the gastroesophageal junction. Then one of the manifestations of gastric cancer is what is known as Lionitis plastica, or the leather bottle appearance of the stomach. And you should know that the Lionitis plastica is not only confined or not only produced by gastric cancer, but it can be seen in many other conditions. And you can remember these conditions by the word plastica itself. And this is not my uh, my this has been I quoted from the internet, and you can see that these causes these lesions can produce the appearance of diffuse gastric thickening and reduction of the gastric lumen, which is known as Lionitis plastica. These include pancreatitis, lymphoma, amyloidosis, syphilis, TB infection, and of course gastric cancer, which is considered the most common. Then this is an example of Lionitis plastica by barium meal, where there is significant reduction of the distal part of the stomach with attenuation of the gastric lumen, and barium is passing directly to the duodenum. And this is also another example of Lionitis plastica with infiltration of the gastric body and pyloric canal. The region has been markedly narrowed with severe irregularity of the wall of the affected segment of the stomach. Then you came to the gast tumors, which are the gastrointestinal stromal tumors. These tumors are previously known as leiomyomas or leiomyosarcoma or leiomyoblastoma, but the literature has agreed about this name, which refers to a mesenchymal tumor of gastrointestinal tract origin. And these tumors are rarely seen before the age of 40 years according to the literature, and the gastric guests are usually small and less aggressive than other GIT guest tumors. And the guest tumors generally occur with these percentages across all over the gastrointestinal tract. The most common site is the stomach, representing about 70% of cases. The second is the small bowel, 20 to 25% of cases, and the anorectal area, about 7% of cases, while the esophagus, retroperitoneum, mesentery, omentum are considered rare sites for guest tumors. These tumors are sometimes asymptomatic because they are small and do not cause a lot of symptoms and may be discovered incidentally. But sometimes the tumor is aggressive and may present with metastasis. The ulcers and hemorrhage are common in these tumors, especially the larger tumors, and the reported incidence is about 50% of large guest tumors may show ulceration and hemorrhage. And in this particular situation, GIT bleeding will be one of the common presentations. Then this is a polyp, let us say, or a filling defect in the stomach, and they see the thickening of the adjacent mucosal folds, the smooth surface of the tumor. There is no evident ulcers, and the ulcers will fill with barium, as you know. Then you need, of course, the help of the endoscope to have biopsies and to confirm the diagnosis. This is another example, and this was confirmed to be a guest tumor at surgery. And this is one of the CT appearances of guest tumor, and this tumor is located near the gastric fundus, and you remember that these tumors may enhance but along the periphery, and the calcium is not common. Also, these tumors do not usually give metastasis to the lymph nodes. But in cases of aggressive lesions, you may find invasion of the adjacent organs, especially the spleen or the pancreas or the bowel, and metastasis to the peritoneum or the omentum. And this is an example of a large guest tumor which is located or projecting from the greater curvature of the stomach, and is clearly appreciated here in the coronary formatted image. This is the stomach and this is the greater curve, and you can see the tumor which is bulging outside. And you remember this was previously diagnosed as leiomyoma or leiomyosarcoma of the stomach. Then the differential diagnosis of guest tumors, of course, will include the leiomyoma, which is commonly seen in the esophagus, about 75%, and is rare along the whole gastrointestinal tract. Then gastric lymphoma or GIT lymphoma is not usually a localized lesion, but it is a diffuse lesion which affects mainly the mucosal folds. And gastro-GIT schwannomas and carcinoid tumors need further evaluation by endoscopy to reach the diagnosis. And gastric lymphoma is one of the stomach is considered one of the common sites of extranodal lymphoma, and 25% of extranodal lymphoma may affect the stomach. Gastric lymphoma represents about 50% of all GIT lymphomas and 5% of all gastric malignancies. The mucosal associated lymphoma, or what's known as the malt lymphoma, represents about 60% of the primary gastric lymphomas. Then other types will include the sporadic lymphoma, which is commonly of the B-cell type, non-Hodgkin type, or secondary involvement by systemic lymphoma, which is usually of the high-grade type. This is the marked lymphoma, which is mucosa-associated lymphoid tissue, and is strongly associated with H. pylori infection. These are low-grade lymphomas and may regress following the treatment of H. pylori infection. And this is the barium meal of a case of gastric lymphoma showing the extensive thickening and hypertrophy of the mucosal folds. You remember when I have mentioned the hypertrophic gastritis or the issue of chronic gastritis, I have mentioned that one of the differential diagnoses of cases of presenting with hypertrophied gastric mucosal folds is the lymphoma together with the hypertrophic gastritis. And lymphoma may also present by focal masses which are indistinguishable from gastric carcinomas. You remember that lymphoma is a diffuse pathology, while carcinoma is usually a focal pathology. But here you can see thickening of the gastric greater curve, and there is a mass involving the lesser curve of the stomach, and this mass has been proved to be gastric lymphoma. And by barium meal in cases of lymphoma, you may see normal, absolutely normal appearance. You can see some filling defects. Commonly you see thickened mucosal folds, and you remember that lymphoma is one of the causes of Leionitis plastica appearance, and there may be sometimes the patient presenting by mucosal lesions with mucosal ulcers. And this is a common appearance of lymphoma infiltrating the gastric wall, presenting by bulboid mucosal hypertrophy, and this is CT gastrography or the reformatted image of the stomach using the multi-detector CT, and this is the appearance of the lymphoma by endoscopy. And gastric lymphoma by barium mean, showing the classic appearance of hypertrophy of the mucosal folds, irregularity of the gastric wall, reduction of the gastric lesion. And this is also a case of Leionitis plastica secondary to lymphoma. And you see the severe reduction of the gastric lumen, the irregularity of the wall, and the hypertrophy of the mucosal folds. And CT is one of the helpful diagnostic modalities for assessment of lymphoma. And in this CT scan, you can see the severe diffuse gastric wall thickening affecting most of the scan part of the stomach, markedly encroaching on the gastric lumen, which contains some of the orally administered contrast as well as air. Then thickening of the stomach wall may reach about 4 centimeters in diameter, and extensive hypertrophy of the mucosa is one of the appearances. And also we remember that Leionitis plastica is one of the radiological findings in cases of lymphoma. And you can use the reformatted images to appreciate the extent of the disease along the gastric wall. And here you can see that the fundus is more or less free, but the greater curvature is affected, and the lesser curve is more affected than the greater curve. And you should remember that lymphoma is not usually associated with gastric outlet obstruction, which is not which is commonly seen, this gastric outlet obstruction, in cases of large gastric carcinomas. This is a CT appearance showing more or less a classic appearance of gastric lymphoma with diffuse, non-uniform gastric mural thickening affecting the whole gastric wall. And this is the reformatted image of another patient, and you can see this is the residual gastric lumen, which is filled by the orally administered gastrografin, while the stomach wall is diffusely thickened by this infiltrating lymphoma involving the whole stomach, as you can see. Then gastric lymphoma against carcinoma. In cases of gastric carcinoma, as I have mentioned, may cause gastric outlet obstruction, while lymphoma is not usually responsible for this. In cases of gastric cancer, the location of the tumor is usually in the distal part of the stomach, the distal part of the body, and the biliary canal, while lymphoma is proximal and may infiltrate the whole stomach. Gastric carcinoma has the tendency to extend outside the gastric lumen, infiltrate the perigastric fat planes, and invade the adjacent organs. In cases of lymphoma, the lymphoma is usually diffuse and involves the whole gastric wall and infiltrates the mucosa, resulting in hypertrophy of the mucosa and maybe reduction of the gastric lumen. Also, metastatic lymph nodes in cases of carcinoma are usually small and more localized and discrete, while in cases of lymphoma, lymph nodes are usually bulky, they are usually amalgamated, and they do not usually contain areas of breakdown. هذا وبالله التوفيق والحمد لله رب العالمين.